And I will talk about our study which we published, I think a few weeks ago in the Journal of Internal Medicine. Background, you all know, of course, that SIRS is a frequent condition and, of course, associated with remarkable mortality. So our study objective now was to evaluate suPAR for the prediction of 48 hours, no matter if this is really useful or if a physician is enough to predict 48 hours mortality, as we heard yesterday, and 30 and 90-day mortality in SIRS patients. Patients were included between November 2010 and April 2013. So in total, we included 902 adult SIRS patients in mostly our emergency department. 520 of them were included in the emergency department, and 382 were included while they were already on wards and hospitalized. 286 of them in normal wards, and 96 were later on also admitted to ICUs. On day one, together with the initial blood cultures, we took EDTA plasma samples for determination of suPAR and also same-day lithium heparin samples for determination of CRP, BCD, and interleukin-6. And also collected, of course, a number of clinical data. To our results. Here, you can see in the publication, it's just shortly a little bit an overview where you can see the total study population, then the patients who died within 48 hours. Here you see the median suPAR 14.7 in those who died within 48 hours and 7.3 in the overall study population. And patient with SIRS, on the contrast, who survived at day 90, 6.8, so less than half of these patients who died shortly. But how does it look for 30-day mortality, which might be more interesting? On 30-day mortality, over 13% of patients included died, so it's a total number of 117. In 90 days, 17% died, so a little bit over 150. And here we see the area under the curve for the 48 hours mortality, which was, of course, the best in all biomarkers. But what might be more remarkable is that if you look on 30-day mortality, it seems that suPAR was superior to the other biomarkers, to the comparators, and also for 90-day mortality, it remained superior to the other comparators. Although with BCD, we had, if you look on the confidence intervals, there is some you can't say this the statistical significance. An ICU admission, all biomarkers were not that good. I have to say suPAR was still the best in this pack of not so good biomarkers with area under the curve of 0.6.1. And if you look on positive blood culture prediction, it was also like that there was a trend maybe towards procalcitonin and also interleukin-6 being a little bit better, but not really a difference between suPAR, interleukin-6 and procalcitonin. Here again we see like the ROC curve analysis for 30-day mortality, where the area under the curve was 0.739, and we see this red line, suPAR was superior to the other biomarkers. We also looked at uni and multivariate analysis, and interestingly, suPAR remained an independent predictor for all kinds of mortality for 48 hours, for 30-day and for 90-day mortality. For 30 and 90-day mortality, another predictor was a positive blood culture, so it was bacteremia and high suPAR levels. These were the predictors for mortality in our patients. So when looking at cutoffs, and of course in a clinical setting we would like to have a reliable cutoff to use in our patients, where we can say if the patient is above this cutoff, we know what to do because we have a diagnosis together with the clinical signs and symptoms, of course. But then you see, even for 30-day mortality, if you use a cutoff from 9.15, we have a sensitivity of 69%, a specificity of 67%. So, it's not something where I, as a clinician, can easily rely on, or it's a little bit difficult, of course. And also for 90-day mortality, even with the optimal cutoff, we have like 64 and 67%. So, what exactly to do if a patient is above the cutoff is, in my opinion, still not that clear, because if it's above, okay, you think, okay, two-thirds, it's sensitivity, you get two-thirds, but if it's 1 out of 3 who dies, you don't get him. On the other hand, there's also 1 out of 3 who won't die above this cutoff. So yeah, you have to think what you're doing. Still, if you look on Kaplan-Meier curve, and use this 9.15 cutoff, you see a clear survival benefit of those patients below this cutoff compared to those who had super values above the cutoff over the whole range of 90 days we observed for mortality. So in conclusion, suPAR plasma levels serve as a prognostic marker in serious patients, and suPAR levels were an independent predictor of 48 hours, 30 and 90 day mortality. And also bacteremia was a significant predictor for 30 and 90 day mortality. What's of course the future? I think our hospital is pretty convinced that suPAR is a useful biomarker. Not no biomarker is perfect, also procalcitonin is not perfect, interleukin 6 is for sure not perfect. I don't know if you need it in clinical routine, but the main thing is, okay, if we use suPAR routinely in our hospital, we would need like an automated quick determination possibility, and if this would be available, of course, we would really think of introducing it, but this is for sure something which is a limitation of the biomarker right now. And also the quick test, which is available, I'm never that happy with quick test. I showed you at the cutoffs, we have a sensitivity of 60% and specificity of 60-something%. So I would like to know the exact value, but still, even if we have a quick test, we would need appropriate cutoffs. So now the cutoffs in the quick test are for our patient cohort are definitely too low. So how will this all change patient care in the future? I just invite you to read the editorial comment by Piana Vasarheli, which is very interesting to read, and I can't add very much on this interesting comment, and also discusses some things, but I think I'm already a little bit over the time and just invite you to read this comment. So thank you for your attention.
Thank you very much. Other questions?
But did you refer to, say, the risk of renal failure or acute kidney failure and prediction of that?
We looked previously on this correlation of different biomarkers with renal function and with creatinine, and we also found that super correlated, of course, with the renal function. So that we had like the different categories, and it was like really good correlation with super. But still, there is something else. It's not just a reflection of creatinine, because if you look on the prediction of if you have creatinine inside this, the area under the curves are much lower. They're much lower. They're like 600 something. They're in the area like CRP or something. So.
Yes, I have just a short add-on question to your comments. Have you looked upon the data from the patient who only fulfills 2 or 3 of the CS criteria? Because that's where I actually think there would be a value for suPAR. Have you looked upon only these?
Overall it was like that 1 out of 9 was admitted to ICU from all the study population. So it's not, it's not a huge thing. It's not that it's for all the ICU patients. But still, it would be interesting. Definitely, I agree. Definitely. Yeah.
I'm afraid we need to move on. Thank you very much.